Assalamu alaikum. I'm Dr. Mohammed Tassaduk and today I will be your speaker, and I'll be uh, delivering you a brief lecture regarding a most common community-oriented problem, especially in females, that is UTI. And today my topic will be covering important aspect of UTI. So my first slide would be on the epidemiology of UTI. It is the most common bacterial infection, and it is most commonly caused by nosocomial infections. And in our society, most of the time it is infected in female population, but males can also get this UTI, and with an annual incidence of 12.1, and peak incidence of UTI in women occurs between the ages of 20 to 40 years. 20 to 30% of women who have a UTI will have recurrent UTI. So this UTI is a bug, is an infection which, if it starts, it doesn't get better. You have to be very careful in treating this UTI. You can take it very simply, but it can become very complicated. So this UTI results in significant discomfort and have a high impact on ambulatory healthcare costs as a result of OPD visit, diagnostic test, and prescriptions. This UTI is more common in postmenopausal females due to residual urine after voiding, which often associated with bladder or uterine prolapse. Because what happens when females get older, so they have hormonal disturbances, and your estrogen concentration gets on the lower side, and you become more vulnerable to catch infections. And in addition, the lack of estrogen causes marked changes in vaginal microflora, and including a loss of lactobacilli, which is a protective organism, and it increased colonization of E. coli. When this lactobacillus is lost from females, then there is an increased colonization of the E. coli. What is the definition of UTI? UTI is diagnosed in women by presence of at least 1 lakh colony forming units in pure culture of voided clean catch urine. This clean catch urine means a lot. That clean catch urine means like urine should be collected on a morning sample, and midstream urine would be most important, because you cannot just give it in any bottle. It has to be taken in a midstream sample, and bottle should be very clean. This UTI are caused by either re-emergence of bacteria from a site within the urinary tract, that is bacterial persistence, or a new infections from bacteria outside the urinary tract. UTI is defined as 3 episodes of culture confirmed UTI in the recurrent UTI defined as 3 episodes of culture confirmed UTI in the last 12 months, or 2 episodes in last 6 months. What are the risk factors? As I mentioned before, that the women are more prone to get infections because of the short urinary tract, and infections tends to reoccur in those short urethra, frequent sexual intercourse, spermicidal cream, and the diaphragmic. What are other risk factors? Post-menopausal females have decrease in estrogen, which leads to thinning of the lining of the urinary tract, which increasing susceptibility to bacterial infections. Pregnancy does not increase the risk of getting UTI, but it can increase the risk of developing a serious infection that could potentially harm the mother and the fetus. It is very important to recognize UTI in pregnancy, because this UTI can lead to your fetal loss, because if you don't treat UTI in pregnant women, it's going to harm your baby. So it is very important to recognize early and to treat early. What is the pathogenesis behind this UTI? The interaction between bacterial virulence and host defense factors can ultimately result in UTI. More virulent bacteria are necessary to infect healthy hosts with normal urinary tract, whereas less virulent bacteria may easily infect compromised hosts. The cause of UTIs in women is usually colonization of vagina and urethra with bacteria from intestinal tract. What is bacterial virulence? It is the initial step in pathogenesis of UTI in bacterial adherence to urothelium by pili. Pili are filamentous adhesive organelles in uropathogenic strains of E. coli because it is the most common organism which causes UTI. So bacterial colonization causes a host inflammatory response which includes neutrophil influx followed by apoptosis and exfoliation of the bladder. Epithelial cells in an effort to rid the bladder of bacteria. This is the picture which is not coming rightly, so we'll just skip and we'll go to the next slide. That pathogens is uncomplicated UTI. Like if we are talking about the normal population, so you can just think that E. coli is the most common cause, which includes 70 to 95% of the population. Second would be Staph saprophyticus, which includes 5 to 20%. 3 is Klebsiella. 4 is Enterococcus faecalis, and the 5th is Proteus mirabilis. I would like to mention one thing very important, that if you are living in a home, so if you are not exposed to any hospital or any public places, then most commonly you will get E. coli. So you don't think about the complicated organism. But if you are catching this infection from public places by using public toilets and by going to hospitals, then we will think there are some other organisms which can cause this. Okay, this slide is a host risk factors in pathogenesis like genetic, anatomic, functional and behavior factors that affect the host susceptibility to uropathogen and its ability to overcome them. Like genetic, blood group, antigen, there are so many factors which can lead to UTI, but all are not compatible to implement on everyone. It is like these are the factors which can involve in any person, like in genetic, blood grouping, antigen, non-secretor status, density of adhesion receptor. Anatomical, congenital abnormalities. Some patients have a congenital abnormality of short urethra or urethral problem. Some have urinary obstruction, urinary incontinence, calculi, residual volume, because especially in old age males and females, there is a problem in which they cannot empty their bladder after voiding. So the residual urine which kept in the bladder causes infection. Then the catheters and the foreign bodies, atrophic vaginitis, behavioral, sexual activity, multiple sexual partners, diaphragm use, spermicidal use, antimicrobial use. Risk factors differ in pre and post-menopausal. In sexually active premenopausal, risk factors are frequency of sexual intercourse, spermicide use, because some of the females using spermicide use, and age of first UTI. If UTI occurring in the early age, like less than 15 years of age, indicates higher risk of recurrent UTI. History of UTI in the mother, genetic factor or long-term environmental also put you at increased risk. In postmenopausal, risk factors are vesical prolapse, incontinence, post-voiding residual urine. Initial evaluation of females with UTI. Most women with UTI do not have anatomical abnormalities and do not need an X-ray. So what you are going to do, assessment should include number 1, history, number 2, physical examination, that include a pelvic examination. Then how you are going to proceed, you will do a pelvic ultrasonography for residual volume of urine. Then you will send urine for CS for documenting that UTI is the cause of symptom. Typically frequency dysuria and hematuria are the symptoms in patients who are suffering from UTI. What are the specialized evaluation for UTI? There are in some congenital abnormalities you need to evaluate by doing either CT scan or by doing IVP should be done, but that should be done by a specialist doctor, not by a general physician. So what you need to remember is you always do a urine dipstick test, urine DR, urine CS, and ultrasonography. But these tests are also need to be remembered by all doctors, that these can be done in a specialized setting. Like patients who are coming with a prior pelvic surgery, ultrasonography for checking, cystoscopy to check the bladder for stitches which can form a nidus for stone or infection. A specialized evaluation for recurrent UTI with Klebsiella, Pseudomonas or Proteus bacteria. Ultrasonography KUB can be done because these bacteria have urease splitting enzyme that can alkalinize urine and may cause formation of strophoid stones. Kidney stones, because these bacteria can cause formation of kidney stones, and which can lead to urinary obstruction. And if the patient is suffering from high grade fever along with dysuria, back pain, that means this infection has went to all the way to the kidneys. So we call it pyelonephritis, which is diagnosed by positive urine, CS, back pain, and high grade fever. What are the differential diagnoses for recurrent UTI? Not all women with frequency, dysuria, and hematuria have UTI. In the case of recurrent UTI, especially with negative cultures, a urological or a gynecological evaluation should be performed in order to exclude bladder cancer, obstructive problems, detrusal failure, vaginal infection, genital infection, interstitial cystitis, and neurological disease. What are the complications of recurrent UTI? Because if this UTI comes again and again, what you can go through? It can lead to very devastating results, which includes acute papillary necrosis, overwhelming sepsis syndrome with shock due to loss of vasomotor tone, capillary leak, impaired myocardial performance. It can also cause perinephric abscess, because these infections can cause abscess formation. So it is very important to understand this infection and to treat early. So what is the treatment of recurrent UTI? Treatment is very easy and very difficult, because you can treat it by giving simple antibiotics just for 3 days, but in a complicated UTI you have to give it for long time, which can up to 2 months, 3 months, even we can put patients for 9 months, especially pregnant women. So primary treatment for recurrent UTI should be guided by culture. It is very important for all doctors to understand that culture should be done before starting of treatment. Even what you can do is, when your patient comes to you, just if you have seen that there is infection present in the urine DR, just send the culture and start antibiotic. But you have to send the cultures and call your patient back within 5 days to know what is the result. Have you given the appropriate antibiotic or not? So it is very important to understand. Secondly, commonly used antimicrobials that act on gram-negative uropathic organisms include trimethopril, cotrimoxazole, which is very commonly available with the name of Septron and Septron DS. Fluoroquinolones, Cipro, Levo, levofloxacin, norfloxacin, moxifloxacin, these all can be used. Nitrofurantoin, this is a very specialized drug. This is very old drug, which is nowadays very less commonly used by the general practitioners, but it is a very important part of our treatment, especially nephrologists, because they are using this drug as a rescue therapy. Because most of the patients, when it comes to us, they are already been taken other drugs, but we start them from nitrofurantoin. Other drugs include beta-lactamase, penicillin, which include amoxicillin, ampicillin-like compounds, cefirodoxil, cefirixime, cefodoxime, like first generation, second generation, and third generation. Duration of treatment of 7 to 10 days increase rate of eradication and minimize resistance to drug. So it is important to treat properly. If you see that there is an infection treated properly. Prevention of recurrent UTI approaches proposed for the prevention. Non-pharmacological therapies include local estrogen for most postmenopausal females, antimicrobial prophylaxis therapy given regularly, or postcoital prophylaxis in sexually active women. Immunoactive prophylaxis. Non-pharmacological therapies other include adequate fluid intake, voiding after sexual intercourse, ingestion of cranberry juice, eating yogurt which contains lactobacilli, vaginal application of lactobacilli, avoiding constipation. What are the prophylactic antimicrobial? Prophylactic antimicrobial can be anyone, especially like we can give nitrofurantoin, we can give fosfomycin. There are so many drugs which can be used prophylactically. There are first generation cephalosporin, but whom you are going to give it? Continuous prophylactic antimicrobial therapy, postcoital antimicrobial therapy, self-start antimicrobial therapy. We have classified into 3 different categories. Continuous prophylactic antimicrobial therapy is one of the effective approach for management in the prevention of infection by use of long-term prophylactic microbials. Taken on a regular basis at bedtime, it is not known which antibiotic schedule is best, optimal duration of prophylaxis, incidence of adverse events, recurrence of infection after stopping prophylaxis, and treatment compliance. These are the factors which you need to understand. Which antibiotic you need to give and which is best for your patient. What will be the optimal duration for prophylaxis? It should not be very few days, it should not be too many days. So it should be optimal duration. Incidence of adverse effect, because if you are giving drug for a long period of time, it can cause adverse reactions, adverse events as well. So you should keep this thing in your mind as well. And recurrent of infections after stopping prophylaxis. This is very, very important, because sometimes what happens when we prescribe medicine, patient takes and they get better. When they stop, after few days, they get another infection. So it is very important to continue checking urine DR. And treatment compliance, it is the most important factor. If you have prescribed your patient, it is important that you should counsel them. It is very important that they should continue the therapy on the prescribed treatment plan. So these are some guidelines, but guidelines are always for assistance. It is not applicable on every individual, in every setting. It has to be individualized. What are the standard regimens? Like prophylaxis we can give nitrofurantoin 50 mg per day, nitrofurantoin 100 mg per day. We can give trimethoprim sulfamethoxazole 3 times weekly. We can give trimethoprim 100 mg per day. We can give fosfomycin 3 gram every 10 days. What is breakthrough infections? Breakthrough infections are those when you stop your antibiotic and patients again get that infection, then you have to increase the dose and you have to give different regimen. And breakthrough infections, you have to give ciprofloxacin 125 mg per day, norfloxacin 200 to 400 mg per day, and other ciprofloxacin group you can give it 800 mg per week. What you can prescribe in pregnancy? There are 2 drugs which we usually prescribe, cefalexin and cefaclor. Cefalexin in 125 mg per day and cefaclor 250 mg per day. Choice of antibiotic. Choice of antibiotic, trimethoprim, cotrimoxazole or nitrofurantoin can still be considered as the standard regimen. Like in cases of breakthrough infection due to resistance pathogen, low doses of fluoroquinolones may be used. During pregnancy, an oral first generation cephalosporin is recommended. Postcoital antimicrobial therapy. It is an alternative prophylactic approach for women in whom episodes of infection are associated with sexual intercourse. If you are thinking that this UTI is coming again and again after sexual intercourse, then you should take prophylactic antibiotic, especially those who have multiple sexual partners. Same drugs can be used in the same doses as recommended for continuous prophylaxis. Self-start antimicrobial therapy, which is very common in our society. People avoid going to the doctors. They start their treatment by their own. You must all be aware of that. It is suitable sometimes for well-informed women in whom they have taken these sort of antibiotics previously. This is not prophylaxis, but early treatment has also an important role. Sometimes if you are living far away from the doctor and you understand your problem and you understand your symptoms, that you are again having the same problem of dysuria, having burning micturition, and again, so then you can start your treatment. But patient should be well informed about all these things. It has emerged in an effort to decrease overall antibiotic usage. It relies on patient's intelligence and recognition of UTI. Patient takes some antibiotics for 2 to 3 days. It always happens because when they get better, they stop their treatment and they don't continue till 7 days. So what happens, that efficacy of that drug, you will lose the efficacy and side effect of prophylactic therapy. Number of patients with recurrent UTI decreased by 8-fold after prophylaxis. So that means prophylaxis is very good choice, especially those women who are having again and again UTI. So it is important you complete your prophylaxis, and studies have shown that those who have completed their prophylaxis, they have a reduced rate of recurrent infection. UTI episodes patients per year is reduced by 95% during prophylaxis. However, prophylaxis does not appear to modify the natural history of recurrent UTI or exert a long-term effect on the baseline infection rate. After stopping prophylaxis, even after extended period, approximately 60% of women will become reinfected within 3 to 4 months. This is very important to understand because some of the bugs like E. coli, if it comes in your body, it will never leave you. Take this thing in your mind and remember this thing. You have to be very careful for whole of your life, especially women of childbearing age. Once they get infected, this infection will continue, especially in your old life, especially after postmenopausal, and the organism will be the same. So it is important to reconsider that you are again having an infection after prophylaxis. If you get any symptom again and again, so you have to think about it. Side effects of prophylactic antimicrobials include vaginal and oral candidiasis and GI symptoms. This is very important because if you are giving antibiotics for a long period of time, you are going to lose a common commensal organism which are protective for your body, which needs to be there, because you are destroying all the normal flora of the body, and which can cause vaginal infection. You will have oral candidiasis and you can have GI symptoms like diarrhea, you can have epigastric tenderness, you can have tummy aches and pain. This all can happen. What happens in pregnancy? This recurrent infection can come in pregnancy as well. Women with bacteria and urine during pregnancy should be put on prophylaxis till delivery. And penicillin or first generation cephalosporins are the first choice. Other options for patients whom are allergic is nitrofurantoin or Septron like trimethoprim and sulfamethoxazole. But it is very important to counsel your patient, because some of your patients will think that if you are going to give them antibiotic, it's going to harm their baby. But you have to tell them that not taking this medication is giving more harm to your baby rather than taking this medication. because if they don't take this medication, your infection will continue. You are at increased risk of having problem with your babies. Women with bacteria with no symptoms and whom are not pregnant do not need to be treated with antibiotics. Cranberry, it is very common and very popular among people, and it is good therapy for UTI. Cranberry is a small evergreen shrub grown in bogs of damp forests and open ponds. It requires wet, boggy, acidic soil. This looks like very nice and very tempting as well, but this is good for UTI. It has been proven. And cranberry is very important in giving patients who are having UTI again and again. Why? Because it contains some products like proanthocyanidin, which can inhibit the attachment of bacteria to the epithelial lining of the urinary tract. And there are so many studies which show that inhibition of bacterial adherence and E. coli and other gram-negative uropathogens that can decrease the rate of UTI. So it has some beneficial role in protection of UTI. And there are so many studies have been done before it has been available for the physicians to prescribe, and these are the main important results. It has a direct antibacterial activity. Cranberry may offer an alternative methodology to antibiotic prophylaxis. Effect on type P fibrinated E. coli. E. coli was observed to be specific to cranberry. 400 mg per day of cranberry shows reduction in recurrence of UTI. In one uncontrolled study, more than 50% of patients had a positive clinical response in recurrent UTI. D-mannose is a sugar monomer of the alpha hexose series of carbohydrates. Mannose is a C2 epimer. This is very difficult. I don't think it is important for you to understand or remember, but the only thing which you need to understand is it has a significant role in reducing bacteria within 1 day. Patients who were treated daily with D-mannose, 95% reported symptom improvement. The right combination. Alternative medicine review suggests the use of cranberry and D-mannose as a natural option for the management of UTI. At the same time, potassium salts are suggested to alkalinize the urine and reduce dysuria. There are other things as well available in the market which you can give, like cranberry extract, D-mannose, potassium magnesium citrate, and they are coming now in sachet, and which you can give it to your patient. But what I prefer is, like, you can prescribe cranberry sachet thrice daily for patients who have active problem, and those who are going for prophylaxis, just once a day is enough for them. Inpatient care for recurrent UTI. Necessity of admission depends upon age, host factor, risk of complicated infection, likelihood of morbidity with failed OPD treatment. Like patients who are on extremities of age, like very young and very old, are very vulnerable, and the urinary tract infection is very fragile, especially in old age patient, and it can be very lethal and life taking as well, because this UTI can lead to sepsis, and it is very important to take it seriously and admit those patients. Patients with structural abnormalities like urinary calculi, indwelling catheters, obstruction, metabolic diseases like diabetes, CKD, HIV, those who have impaired immune response and who have got UTI, they should be admitted and they should be taken IV antibiotics. Patients with uncomplicated pyelonephritis should also be admitted. Patients unable to maintain oral hydration, shock-like symptoms, fever unresponding to antibiotic therapy should also be admitted. Patients with debilitating pain or dehydration that cannot be corrected in OPD, they should also be offered for admission. Patients with inadequate home care or resources to comply with medical regimen, they should also be admitted. Because it is very important to understand that this simple UTI, which can be treated with simple antibiotic, can be life-threatening as well. So we should take it very seriously. So what are the take-home messages? That recurrent UTI are a major issue for many women, especially they are commonly costly and and they can cause considerable morbidity. Patients with recurrent UTI should be properly investigated by lab radiological techniques to exclude complicated causes or gynecological problems. Prophylactic therapy proved efficacy with decreased rate of recurrence, minimal side effect, and drug resistance, but without alteration in natural history of disease. Thank you.